My name is Dr. Dolores Pretorius, and I'm going to give part 2 to my congenital anomalies talk on the basics. Cystic hygromas are fluid collections in the posterior part of the neck, seen there most commonly. Those are the ones that are associated with abnormal karyotypes like Turner syndrome, trisomy 21, trisomy 18, trisomy 13. And when you get this cystic hygroma, they can be associated with hydrops and lead to congenital lymphangiectasia. So whenever we find a cystic hygroma, like you see here, this large fluid collection behind the neck, and you can see the cerebellum right here, and the cisterna magna, then we always look for other signs of hydrops, like in this patient with a pericardial effusion and a pleural effusion. There's the fetal heart and there's the spine. Now, Turner syndrome often have cystic hygromas and the hydrops that goes with them. They can also have cardiac anomalies like coarctation of the aorta, like you see right here. And they can also have horseshoe kidneys, like you see in this patient with the spine here and the kidney going circling around and joining the other side. Here is the hydrops with the skin thickening that you can see around this fetal abdomen with the stomach there and the spine here, and these are ribs. Cleft lip and palate, I'd like to review with you. It's a relatively common 1 in 700 or so cases of births. Here's a normal lip that is in part of the normal AIUM guidelines. Here's a cleft lip that you can see is unilateral only on this side going up into this nostril, calling it a complete cleft. And then here it is on 3D ultrasound. Now, about 10% of these will have associated anomalies at birth. We also go and look at the palate. This is a normal palate with the alveolar ridge here, and those are the tooth buds, and these clefts generally occur through this lateral incisor right here. And here you can see one in this abnormal fetus with the alveolar ridge that's broken. Okay, moving on to chest masses are congenital abnormalities such as the congenital pulmonary airway malformation, pulmonary sequestration, diaphragmatic hernias, and pleural effusions. Here's a CPAM, also called congenital pulmonary airway malformation, and you can see the heart is right here, and it's being pushed over a little bit by this echogenic mass. And here it is on the sagittal with the diaphragm and the ribs, and here's this bright white area. So this could have been a sequestration, but it turned out to be a CPAM. Diaphragmatic hernias will present with an absent or displaced stomach, deviated heart when you look at your 4-chamber view. Sometimes you can actually see bowel in the thorax with peristalsis, and these will often have polyhydramnios. So here's a patient that the heart is being pushed way over to the right side of the chest. There's the spine with the shadow, and here's the stomach pushing it way over. And on a longitudinal scan, the diaphragm is here, and you can see that the stomach is up in the chest, right behind this the heart. There's the ribs coming down. Now, we often go to MRI for our diaphragmatic hernias, and here you can see the stomach and the bowel up here in the chest. There's the heart. And here it is again with the stomach and the bowel loops up with the normal lung over there. And here's one that we sent for a possible, and it wasn't picked up by this view, but when you looked at the normal opposite side and that lung, then you could realize that this really was bowel loops up in the chest. Next, moving on to cardiac anomalies, we think about arrhythmias. So you always want to check and make sure the rhythm is normal, and the normal fetal heart rate is 140 beats per minute. And then structural abnormalities like hypoplastic right heart or left heart. And we always want to look at situs to make sure that the heart is on the right side and the stomach is on the left side, the correct side, because they can be a sign of congenital heart disease. So first, the four-chamber view is one of the first views that we always take a look at. And we want to see the heart in the chest anterior to the spine coming across at about a 45-degree axis. And I have a clip of it here to show you as well. I tend to think of this list like to go along with this diaphragm with the right ventricle here and the left ventricle, and then the two valves and the two atria with the foraminal flap in between, and there you can see it. So I tend to think of these in groups of the first is the global things, that the heart is about a third the size of the chest and that it's at a 45-degree axis from a line that you would drop between the sternum and the spine. And then the next four are basic things, equal-sized ventricles and atria, a septum that's intact, and often we will come perpendicular to it to prove it because there's an artifact that often fills out here that looks like a defect when it's not. We also look to make sure the crus is intact because that will rule out an AV canal. We look for the moderator band down in the right ventricle. Oh yes, and we look for this offset of the tricuspid valve is a little bit lower than the mitral valve. And the left atrium is always closest to the spine to help you get that bearing. Then we kind of look at the last four, which is that moderator band is the first, and then that there's no pericardial effusion, and that the aorta is on the left side of the chest, the same as the heart, and that pulmonary veins enter into the left atrium. And we tend to use color to say that. And that's to rule out anomalous pulmonary venous return. So here is a case of an AV canal where you can see a hole in the middle of the heart. And here's our normal for comparison where you see that nice crus. And here's another AV canal just to show you that it can be hard. On the clip, you may need to slow down your clip to be able to see that there's a hole in the middle of that heart. Here you can also see that there's a hole in the middle where all of this color is, and it's got the hole during diastole, whereas during systole, here we go, you will not see it. So there it almost looks normal, and yet when you go to systole, it's wide open. And then here is a patient with a hypoplastic left heart. You can see the right ventricle normally, right atrium, left atrium, but there's really no left ventricle there. Okay, the outflow tracts are also part of our guidelines for heart disease, and this is the left ventricular outflow tract. Here it is on this clip right here, and we want to see that the septum is intact, so we're looking for high membranous VSDs, which 70% of VSDs are high membranous VSDs. And then we want to look to make sure that the aorta merges with the septum and that there's no overriding of the aorta. We want to see that valve come and go so that it doesn't have aortic stenosis. And we want to make sure there are not two parallel vessels, because when there are two parallel vessels, we want to think of transposition of the great arteries, like in this case right here, and they are parallel at the level of the valves. The right ventricular outflow tract is right here with the aorta in the middle and the pulmonary artery shooting straight back to the spine, and that's the pulmonary artery. Now, the things we look for on this are that there is a branching of the ductus and the right pulmonary artery, that the aorta is just a little bit smaller than the pulmonary artery, and that valve, again, comes and goes, and it's perpendicular to the vessel, and we're ruling out pulmonic stenosis by doing that. Now, the 3-vessel view and 3-vessel trachea view were just put into the new AIUM OB guidelines in 2018. And the 3-vessel view is the pulmonary artery, the aorta, and the SVC, just like on this diagram, pulmonary, aorta, SVC. And the pulmonary shoots straight back to the spine, like I told you before, and it's a little bit bigger than the aorta. And then that is a little bit bigger than the SVC, and they tend to come down in this level. The trachea is behind it right here, and that is, we call it PAST for past. to remember PAS and then T underneath. Just above that is the 3-vessel trachea view. And this is the pulmonary artery and the aorta coming together. It's much easier to see in color than grayscale. And then the trachea is off to the side here. Now, once in a while, you'll see the azygos just coming back in if you turn on color there. And it will be, of course, the opposite direction than the aorta. The thymus also lives right up here. And that's important because absence of the thymus is seen with 21q deletion syndromes, which are common in congenital heart disease. Okay, so I just wanted to show you a couple abnormals. So like here's coarctation of the aorta with a big pulmonary artery and a smaller aorta that's very similar in size to the SVC. And that would be a suggestion that you should be looking for coarctation of the aorta. And here's an abnormal 3-vessel trachea view with a right-sided aortic arch. The trachea is in between the ductus and the right side, and you can see this on color Doppler. And this can lead to a vascular ring, which does need to be delivered in a tertiary hospital in case there is stridor at delivery. And once again, that trachea is supposed to be on the outside when you have a left-sided normal arch, but this is abnormal with a right-sided arch. Okay, GI tract abnormalities that you should think about are TE fistula, diaphragmatic hernia, which we already discussed, duodenal atresia, and then omphalocele and gastroschisis. So the double bubble in utero, similar to the appearance in a neonate, has 2 cystic collections rather than air collections. That's the stomach and the duodenum. That's the gallbladder over there. And we should be thinking about duodenal atresia, can also be Ladd's bands, annular pancreas, duodenal web, malrotation, and these will often have polyhydramnios and significant polyhydramnios if they can't get any fluid through a duodenal atresia. So in Down syndrome, up to 30% of these will have Down syndrome, so you always want to go look for the other markers of trisomy 21 in these cases. This fetus had a double bubble at delivery, and prior to delivery, it had an amniotic fluid index of 53 at 31 weeks, which is very high. And this fetus did have trisomy 21. It also had an annular pancreas. Both of those go along with trisomy 21. So what are some of the things you think about for Down syndrome? We often will get a positive quad screen test or a sequential integrated screen test where we test for the alpha-fetoprotein, the HCG levels, the estriol, and the inhibin. Many of these patients will go on to have non-invasive prenatal testing, which is a blood test where you check for the cell-free DNA, and that has a 99.1% pickup rate for trisomy 21. And of course, patients with advanced maternal age over 35 years of age. The soft markers that we look for, I always say, think of it as going from the head down. Think of the nasal bone, short or absent nasal bone, nuchal thickening greater than 6 millimeters, an echogenic focus in the heart, which we see every single day in our practice, echogenic bowel, pylectasis, and short femur and short humerus, independent markers. Then the anomalies that I think of for Down syndrome, again, start at the top: ventricular megaly, cleft lip and palate, cystic hygromas, cardiac anomalies, which will occur in about 40%, unilateral pleural effusions, and then what we've already discussed, duodenal atresia and annular pancreas, also TE fistulas. So just a few pictures of these markers. There's an increased nuchal fold greater than 6. Here is an absent nasal bone right here on this profile. Here's a little tiny echogenic focus in the left ventricle, and here's some echogenic bowel. Okay, moving on to omphalocele. These occur about 1 per 4,000 pregnancies. 50 to 75% will have associated anomalies. Chromosomal anomalies are seen in about 40% of these. And if you have a covering membrane, that is a sign of an omphalocele. The cord generally enters into the defect rather than to the body proper, but it often tracks right along the bottom of the omphalocele, so it can look like it's a normal cord insertion. These are also associated bowel atresias. So here's 2 different cases of omphalocele where you can see the cord comes in and just goes adjacent to it, but then it dove down and then went into the belly. This one you can see the ascites, both inside the abdomen proper, where you can see the spine shadowing, and also into the defect out here, where there's also liver out. You can see that membrane. Later on, they can have bowel obstruction, and these will often have associated anomalies. There's a picture of this one right here. We can make this diagnosis early, even though we have physiologic herniation of bowel that comes back in by the end of the 11th week. Here's a baby at 12 and 6, and you can see this omphalocele right here. There's the head, and there's the body, and there's the omphalocele coming up. And when you look in transverse, the spine's over here, and here's the defect coming out. These were twins, and twin A had a normal cord insertion that we should normally see, whereas this one did not. This baby went on, and at 16 weeks, you can see the liver and bowel out, and there it is on a sagittal view, and there it is on a rendered view. This baby ended up having a demise at 26 weeks and 6 days, and the twins went on to deliver at 34 weeks, but had a normal delivery of twin A. Gastroschisis is a little less common, but there seems to be an epidemic amongst teenagers, and we think it might be related to trans fats from fast foods. They have less frequently have anomalies, most of them in the bowel, only occasionally in their hands or brain. They do not generally have a membrane, and the cord enters into the abdomen. The defect is on the right side in most cases. So the findings for us on ultrasound is no membrane. You just see these loops of bowels out that look like, I would say they're like cauliflower-like or finger-like projections. They may have thickened bowel loops, and they may end up with obstruction due to an atresia. So here's some thickened bowel loops floating around out there. And on this rendered picture, you can kind of see these bowel loops very well because of the fluid. And this is what it looked like after birth. Okay, next I'd just like to review echogenic bowel. Sometimes these look like little light bulbs, and sometimes it's just like the walls of the bowel. Findings that we look for, they can be associated with aneuploidy, so many people will go on to NIPT. They can be associated with cystic fibrosis. We always have our genetic counselors talk to these patients so that they can do testing for cystic fibrosis and for infection like CMV. And they can also be related to swallowed blood. So if we get a bleeding history from mom, we are hopeful that that is the reason for the echogenic bowel. And then, of course, they can just be normal. Okay, the skeletal dysplasias, you always want to look at the long bones, and if they're short, you want to think about skeletal dysplasias. Most of the dwarfs will have polyhydramnios. They can go on to have hydrops. They can have CNS abnormalities, but the thing that's most important is looking at their thorax to see whether they're going to have a fatal anomaly, and the thorax be so small that it won't be able to have, that they will have pulmonary hypoplasia. So this is a thanatophoric dwarf, which is the most common skeletal dysplasia. It means death-seeking. And you can see that it was 29 weeks here when this was identified. And the bones here are measuring, the head is at 29 to 30 weeks, and the limbs are at 15 to 16 weeks down here, way below the second percentile. And this is a classic appearance of a short, they call them telephone receivers. Now that you have cell phones, you don't even know about telephone receiver appearance, but that you can have telephone receivers with other skeletal dysplasias, so it's not exactly specific. Here's the the heart in this chest, and so it's filling up a large part of the chest, and the thoracic cavity was small. This baby had cloverleaf skull, which is a finding that goes along with Thantophoric Dysplasia, where you get synostosis of these sutures. And then here's some abnormal looking bones down here in the tibia and also the femur. Clubfoot is a common abnormality. It's supposed to be the #1 congenital abnormality from the CDC. And we look for this in the sagittal plane, not the coronal plane. We found it's better, even though we can still overcall it in a large series from Boston. Whenever you find a clubfoot, you want to go and look at the spine and make sure there aren't spinal abnormalities. These are commonly and most commonly isolated, and the kids will do great. And we send all of ours to the club clinic at our children's hospital, where they get casting on a routine weekly basis for the first 10 to 12 weeks. But they can be associated with karyotype abnormalities like trisomy 18. So you want to look at the rest of the fetus and make sure you don't find any other anomalies. Here is a clubfoot at 19 weeks, where you can see the long bones coming down, and then you see the foot on FOSS, like in your hang 10 position, as you do on this 3D picture, whereas a normal ankle should have the sole of the foot here being seen rather than the foot in FOSS. Okay, I'd like to just review Hydrops. We think about immunity problems like RH and Kell factor and things like that. They still do occur, even though they're not as common as they used to be. But there are also non-immune causes of Hydrops, from cardiovascular disease, from twins, from infections like Parvovirus, lymphangiectasia, which we've already reviewed with cystic hygromas, with abnormal chromosomes, pulmonary problems, skeletal dysplasias, and then also placental and cord abnormalities can lead on to Hydrops. We look for skin edema, ascites, pleural effusions, pericardial effusions, and you need at least 2 of these above to call Hydrops. So here's a baby with parvovirus that has ascites here, and you can probably see there's a little tiny bit of pericardial effusion there, also right here on the floor, going through the thorax. Okay, now I'd like to just finish up with some twins and multiple pregnancies. One of the things that we often think about with multiple pregnancies is twin transfusion syndrome, because it's specific to twins, conjoined twins, acardiac twins, and then you can see anomalies in twins just like we do in singletons. Anytime we're looking at twins, we want to look for the chorionicity and amnionicity, because that impacts their management. We want to look for the comparison of the fetal size, and if it's greater than 20%, there's much more concern. We want to estimate the amount of amniotic fluid on either side of the membrane, and we just give a single pocket. We don't do an AFI for twins. It's too hard to figure out which pockets are each twins. And then we want to dictate genitalia, because it helps us in figuring out amnionicity and chorionicity. So first we look at sex, and if they're 2 different sexes, then we think these are likely diamniotic, dichorionic. Once in a while, if it's a mosaic problem from infertility, IVF pregnancies can have different genders and still be dimo, but it's uncommon. Then we look at the placenta, and if there are 2 placentas, then it's going to be diamniotic, dichorionic. But if it's a single placenta, you don't know. And then we look at that membrane in between. And if it's thick, we think it's most likely di-di. If it's very thin, we worry about dimo. If it's got a twin peak, and I'll show you that on the next slide, then we're going to call it diamniotic, dichorionic. And if there's no membrane that we can find at all, we're going to look and see if it's a monoamniotic, monochorionic pregnancy, or whether it's stuck against the wall of one of those twins. So if you come from 2 eggs, dizygotic, then 100% of the outcome will be diamniotic, dichorionic, but they can have either 2 placentas or 1 placenta with that 4 layers of membrane in between. If you're monozygotic and you come from 1 egg, then 20% will be di-di, and 80% will be diamniotic, monochorionic, and then 1% will be mo-mo. The di-dis get followed every 4 weeks for growth and looking at the cervix to see if they're in preterm labor or short cervix. And then monozygotic our dimos get followed every 2 weeks, looking for twin-twin transfusion and for signs of short cervix. So a twin peak is the placenta of a di placenta growing up between those two layers of chorion. Some people call it the lambda sign. Most people call it the twin peak in the United States. And then if it's perpendicular, it can be di because the twin peak isn't along the entire membrane, only parts of it. But monochorionics will all have a T throughout the placenta. So here's a twin peak coming in between, and here's a very thin, wispy membrane on a dimo that you don't see any twin peaks. So what do we look for in twin-twin transfusion? It says when there are anastomoses between the two placentas with shunting of blood from one twin to the other, so that one twin becomes anemic and one becomes fluid overloaded, and these only occur in the monochorionic placentation twins. We look for growth discrepancy between the twins. We look for hydrops in one or both twins. We look for polyhydramnios around one and a stuck twin with oligo around the other. We look for non-visualization of the bladder in that twin that's stuck that doesn't have enough fluid around it. We look for that thin monodi membrane, and we also do a lot of Doppler studies that help guide treatment for these cases. So here's a set of twins that has the twin transfusion, and twin A is at 19 weeks, and one is at 19 and 3, whereas twin B is at 18 and 5, and you might think that's okay, but this whole fetus is smaller than this one. When you look at the fluid, twin A has a lot more fluid around it. It has a pocket here of 10 centimeters. That's twin A, and twin B has this membrane draping around B, and I think this fluid collection was only about 18 millimeters or so. They had abnormal Dopplers. With this one had more diastolic flow than this one did in its umbilical artery, so the Dopplers were helpful. And here's another twin that is stuck hanging up, defying gravity against the anterior wall. And here's a stuck twin down low, but you can see this membrane just draping alongside this fetus. The treatment for twin-twin transfusion is a number one thing we do today is laser ablation of the anastomoses between the two twins, but that's fetal surgery. And if there's not fetal surgeons available to be able to do it, then we do reduction amniocentesis in the polyhydramnios sac. Conjoined twins occur 1 in 50,000. We've all heard of them on television. We don't see them too often. In our practice, we might see one a year. They're most commonly joined at the chest and abdomen, like in this case, where you can see the spine here and here, and the combined at the livers, and there's one heart and there's the other heart. This one is combined at the head, which is only 2%, but I've seen several of these. So even though it's rarer, it does happen. And we had one just last week in our practice. And here it is on MRI, which can be very helpful in figuring out which organs are joined and whether they can survive or not. Thank you very much. I hope you've learned something about congenital anomalies in these two talks.